Hello, everyone. It's Ulrich Sidney here, President of the Association of Future African Neurosurgeons and Research Associate at the Program Global Surgery and Social Change at Harvard Medical School. Today, we have a very interesting presentation on the acute decompression, management of acute bony decompression of the optic nerves and other cranial nerves. This will be presented by Arsene Nyalundja. Before we start, we're going to have every panelist present themselves. So, Dr. Musindo, can you please present yourself? You're on mute, Dr. Musindo. Can you unmute?
Yes. I am Musindo, resident of Neurosurgery in Mozambique.
Okay, nice to have you. Thank you so much. Marvin, can you present yourself, please?
Yeah, hi everyone. I'm Dr. Marvin, PGY1 Neurosurgery, Ivory Coast.
Okay.
From Cameroon.
Okay. Thanks. Great. Now, Arsene, you can go ahead and present yourself and start the presentation as soon as you.
Okay. Hello, everyone. I'm Arsene Daniel from Catholic University of Bukavu, and I'm a medical student in the final year. Today we are presenting an amazing subject which is called acute bony decompression of the optic nerve. So at the plan for this presentation, we'll have an overview, an epidemiology, the anatomy of the optic nerve, pathophysiology of the optic nerve, evaluation of traumatic nerve injury, and neuroimaging assessment, management of the traumatic nerve injury, and then we'll conclude at the end of this presentation. So, at the first point, the traumatic optic neuropathy is a devastating potential complication of closed-edge injury. The hallmark of an optic neuropathy, traumatic otherwise, is a loss of visual function, which can manifest by subnormal visual acuity, visual field loss, or the color vision dysfunction. Visual loss associated with the traumatic optic neuropathy can be partial or complete, and temporary or permanent. The trauma can participate in various pathophysiological conditions that ultimately manifest as the visual dysfunction. The trauma-induced injury to the optic nerve can occur anywhere along the nerve, as in intraorbital to the intracranial length of the optic nerve. The direct traumatic optic neuropathy is a term used when the optic nerve is lesioned, crushed, or transcended. These injuries are usually the result of the cranial trauma, such as penetrating wound or extensive crush injury with displaced craniofacial fractures. Indirect traumatic optic neuropathy occurs when in the absence of the direct nerve injury and is common than the direct traumatic optic neuropathy. Historically, the treatment paradigm advocated for the traumatic optic neuropathy are observation, medical corticosteroid therapy, or the canal decompression. Transcranial unroofing of the optic canal was surgical procedure of the choice. A transethmoidal optic canal decompression, which is generally performed by removing the lamina papyracea and medial wall of the optic canal. Although this technique was refined by progressive advance in transnasal, transantral, transorbital, and the external paranasal sinus surgery. Recent advance in endoscopic instruments and intranasal sinus surgery technique have been refined extracranial surgical approaches for trauma optic neuropathy, endoscopic nerve decompression via intranasal and transethmoidal or transphrenoidal approaches and gain popular supports. According to the epidemiology, in the US, the incidence of indirect traumatic optic neuropathy is approximately 2 2.5% in patients with mid-phase trauma and 2 up to 5 patients with closed head injury. Internationally, the incidence of indirect traumatic optic neuropathy in the Western world is reportedly according to 0.7 up to 5%. Most clinical surveys in Western literature involve a fewer than 40 patients. Higher incidence of indirect traumatic neuropathy is reported in some Japanese studies. However, reasons remain unclear. The UK literature reports that the vast majority of traumatic optic neuropathy patients are young males, up to 79 to 85, with a mean age of 34 years. Traumatic optic neuropathy is commonly caused by motor vehicle, bicycle accident, and falls are the next common cause, followed by physical violence and recreational supports. The optic, now we are going to discuss the anatomy of the optic nerve. And the optic nerve, as we know, is a central nervous system fiber pathway connecting retina to the brain. The two optic nerves exit from the optic canals and rise at an angle about 45 degrees to unite at the optic chiasm. There are nearly 1 million ganglion cells and their axons that make up the optic nerve, and about 90 fibers in each optic nerve arise from the macula. The nerve is 1.5 millimeter by 1.8 millimeter vertical ellipse, and it appears as a pink to yellowish disc. Myelin in the optic nerve is formed by oligodendroglia. The axons are unmyelinated in the retina and the papillary surface, but became myelinated at the posterior and the end at the posterior end of the optic nerve head as they pass through one of the 200 to 300 holes in the lamina fibrosa. The optic nerve extends from retina to the optic chiasm. It's approximately 5 centimeters long. Conventionally, it's divided into 4 parts. The first is intraocular, which length 1 millimeter, and it corresponds to the disc. We have at the second position an intraorbital part of the optic nerve, which is about 25 millimeters. To the third position with intracranicular portion of the optic nerve, which is about 19 millimeters length, and at the last position we have intracranial portion of the optic nerve. It's also important to know that the optic artery and some filaments of the sympathetic carotid plexus accompany the nerve through the optic canal, and this canal is located within the lesser ring of the sphenoid, which is one of the bones that comprise the orbital roof. The optic canal is separated from the superior orbital fissure by the optic strut of the sphenoid bone. Hence, the optic strut comprises the optic canal lateral wall. The canal's medial wall separates it from the sphenoid sinus. And here we have so the next slide, please. And here we have a picture which shows the different parts of the optic nerve. As we say, the points corresponding to A is what we call the intraocular part of the orbital. This part corresponds to the disc, as we said previously, and the parts which correspond to the B segment, which is the intraorbital part of the optic nerve, and the C, which is between two blue landmarks, correspond to the intracanacular portion of the orbital nerve, and the last part correspond to the intracranial part of the orbital nerve. Now we are going to discuss about the pathophysiology of the optic nerve injury. It is important to know that the exact pathophysiology of the traumatic optic nerve neuropathy is poorly understood until now, but the common hypothesis, the common theory, according to the optic nerve neuropathy, is associated with the fracture of the orbital complex. In some cases, no fracture can be identified, especially in post-traumatic nerve dysfunction. And the most common mechanism of the post-traumatic optic neuropathy is likely a compressive edema or vascular insufficiency. Other mechanisms, hemorrhage and laceration of the intracanacular optic nerve by fracture fragment, was described in some literatures. Optic nerve lesion was classified into primary and secondary by Walsh, and traumatic optic neuropathy in its most common form is an indirect event that occurs during or shortly after blunt trauma to the superior orbital rim, lateral orbital rim, or to the frontal area or in the cranium. Now we are going to discuss about the 6 categories of the optic nerve injury whom was described in literature. These 6 categories include laceration, bony deformation or fracture, vascular insufficiency, contusion, concussion, and hemorrhage. A scheme is considered the secondary event that give rise to the neuropathy. The cellular and the subcellular events that constitute the mechanism of neural damage are only now being realized. The role of oxygen, free radicals, enzyme, cytokine, intracellular calcium, and other forms of the reperfusion damage are slowly being uncovered through the basic science research. A less common form of traumatic optic neuropathy that involves the intracranial optic nerve results from forces delivered by the brain shift at the moment of the impact. The rationale for medical and surgical treatment of an indirect traumatic neuropathy stems from the belief that trauma creates a mechanical shearing on a proportion of retinal ganglion cell axon and subsequent edema of the optic nerve. This swelling within the rigid confines of the bony optic canal caused further trauma to the previously undamaged retinal ganglion cell, and it makes some perturbating in the vision loss. Therefore, in a theory, decreasing this swelling and may halt further damage at a limit secondary damage to the optic nerve. Here we have a kind of image. It is from it is an MRI image which shows some fractures of the orbital complex for a young old man who sustained orbital and traumatic foramen fractures. To the image where we have an orbital apex fracture in region of the optic foramen, while a row, and the image on B position show a fracture in medial and lateral orbital wall fractures. The lateral orbital fracture wall fracture is impinging the lateral rectus muscle. According to the evaluation of the optic nerve, traumatic optic nerve injury, the diagnosis of traumatic optic neuropathy is first clinical. The patient with mid-facial and cranial trauma should be an high index of suspicion of traumatic optic neuropathy. Although in some cases, patients with optic nerve injury may have no visible sign of traumatic injury, and features of traumatic neuropathy include ocular involvement, reduced visual acuity, pupillar defects, impairment of color vision, variable visual field defect, and changes in the optic disc appearance on the fundoscopy. An initial assessment of visual acuity for each eye is possible and is very crucial. Unfortunately, concomitant head and facial injury often complicate the initial evaluation of visual acuity following head trauma. And indirect injuries to the optic nerve can be classified into anterior and posterior. A comprehensive ophthalmic examination for patients in whom the traumatic optic neuropathy is suspected includes the following assessment: ocular adnexa, visual acuity, pupillar reaction, and intraocular pressure at the lab, a ophthalmoscopy. According to Edmond and Gottfredson, decreased direct pupillar response to light is stated is not as the most reliable index of optic nerve compromise. While on lateral optic nerve injury, the initial pupillar size is equal bilaterally. However, upon direct light stimulation of the impaired eye, pupillar constriction occurs more slowly and to a lesser degree or not at all than if the stimulus had been applied to the normal eye. Assume optic nerve dysfunction when a loss of best corrected visual acuity or visual field is accompanied by an ipsilateral relative afferent pupillar defect. That is called the Marcus-Gankpe. This is not reliable when the patient has bilateral insults. It is important to note that, however, that if bilateral optic neuropathy is present, however, optic injury is present, pupillar defects, this we call the Marcus-Gankpe, may be more subtle or not be present at all. But visual evoked response and electroretinogram may be provide additional information to guide long-term clinical management. Good correlation between the initial visual evoked response and ultimate visual acuity has been described, and in some settings, the visual evoked response may be superior to the clinical assessment in determining outcome of visual acuity. Greenberg and all describe a 90% predictive accuracy with visual evoked response testing as opposed to 30% with clinical examination in series of patients with retrovilar dysfunction examined within 3 days of insult and again at 3 months or longer. Now we are going to discuss about the neuroimaging assessment of the optic nerve neuropathy. The procedure of choice is a thin section computed tomography as it allows resolution of the bony detail of the orbital apex region. A thin section CT scan also provides an intraoperative roadmap of the surgeon in patients who require surgical decompression. Axial and coronal CT scans can be obtained, and this may demonstrate orbital fractures and bony fragments. Surgeons who wish to perform image-guided optic canal decompression need to obtain a special order CT scan that is formatted to their computerized stereoactive localizing system. Reconstructed image including three-dimensional view, and this can also assist in detailed evaluation of fascial and orbital injuries. It must be remembered, however, that it has been reported that compressive bony fragment not observed on preoperative CT imaging have been found at operation. CT scan provide adequate imaging of orbital soft tissue and is better than MRI at delineating bony defect. MRI may demonstrate soft tissue injury and hemorrhage or hematoma within the dural sheath or optic of the optic nerve. According to the management of the traumatic optic nerve, it is important to know that the mostly accepted contemporary treatment for traumatic optic neuropathy include observation, steroid, and tactical decompression, but concern about the use of corticosteroid in patients with acute brain trauma is led to recent recommendation not to treat traumatic optic neuropathy with steroids. Corticosteroids play a prominent role in the management of optic nerve injury, and the most regime calls for initial loading dose of 30 milligram per kilo followed by 15 milligram per kilo infused every 6 hours for 3 days. Several studies utilizing corticosteroids report substantial improvement of visual acuity. In one meta-analysis, treatment, corticosteroid extracranial decompression or corticosteroids plus extracranial decompression improve visual acuity than observation alone. And no difference between treatment modality could be found. In contrast, there are other studies that do not show any benefit for steroids over observation, most prominently the report from the International Optic Nerve Trauma. Now, most international optic nerve trauma study was conceived to compare extracranial optic nerve decompressive surgery plus corticosteroid with corticosteroids alone. Unfortunately, enrollment of eligible patients was insufficient to provide statistical validity. The study was changed to an observation study, and the result of this study suggests no difference in traumatic optic nerve injury outcome between observation corticoid and the compressive surgery group. And in 2011, a review was published in the American Journal of Ophthalmology that concludes that high-dose steroids could be harmful when given to head trauma patients for optic nerve injury. The review also concludes that surgery should be reserved for conscientious patients with delayed visual loss or whose vision does not improve in 4 days. In one meta-analysis, any treatment, according to corticosteroid, extracranial decompressive or corticosteroid plus extracranial decompression, improve visual acuity more than observation alone. And the indication for optic nerve decompression, we can list the duration of visual loss activity during or after corticosteroid treatment. Optic canal compressive fragment, this must be discovered on imaging, as it's mentioned. And the other indication for the compression of optic nerve take into consideration decreased vision persisting up to 1 year after injury. Some literature, such as Emmanuel and colleague, encountered 26 patients in a 10 years period within traumatic optic neuropathy, and all patients were treated with system steroids. All patients require a surgical treatment because of poor response to medical therapy. It consisted of an endonasal endoscopic decompression of the optic nerve, and improvement of visual acuity was achieved in 65% of the cases. No complication occurred with follow-up time of 24 months. An important of visual acuity was achieved, although very limited in some cases when surgery was performed as close as possible to the traumatic event. They conclude that the surgical decompression offers best outcome for patients in medical therapy failed, and if surgery is done within 12 to 24 hours. Several reports document improved visual acuity outcome for decompression performed within 7 days of injury compared with decompression performed after 7 days. Other studies have not found this time or this period to be a significant factor in visual outcome. And no agreement as to whether the presence of such a fracture is prognostic of the visual outcome. Some reports document worse visual outcome in patients with suffering orbital apex fractures, whereas others find no difference in outcome between patients with and without such fractures. The surgical approach is dictated by the mechanism of the and the location of the insult, as well as the associated injury, especially associated fracture. That is, and then we are speaking about the fracture of the orbital complex in a context of head trauma. The presence of fracture will lead to a best selective surgical approach on the basis of the type of the fracture and the direction of compression, if this can be determined by preoperative radiologic study. In the absence of clear pathology, adequate decompression of the cranial, adequate compression of the cranial of the canal should be possible regardless of the direction of the approach. And it is important to note that there are various approaches for cranial nerve decompression, and we can list some of them. The main categories of the optic nerve decompression, such as the transfrontal approaches, the transethmoidal approaches, and the lateral approaches. According to the first one, which is a transfrontal approaches, it is important to know that these approaches it is important to know that this approach, the transfrontal approaches, was dictated in 1922 by Dandy for orbital tumor and is frequently utilized. This approach allows to exposure. This approach allows to exposure, particularly the intracranial pathology, and requires surgical attention. According to the transethmoidal approach, this was originally described in 1926 by Sewell and was popularized and modified by Neo and all, and some surgeons like Foucault and Tofferman and others. The benefits of this approach, it avoids a craniotomy and provides exposure of the major orbital apex to the fracture of the lateral wall. It can help to minimize the morbidity. At last, we have the lateral approach. According to the frontal approach, as we said, it's allowed to visualize the optic nerve and the optic chiasm. In case of frontotemporal injury, inspection of intracranial optic nerve, optic chiasm, and posterior aspect of the optic canal is due to the access of this structure. Dural truss and orbital plate fracture can be repaired, and associated intracranial pathology can be addressed concurrently. The optic canal can be unroofed, and the dural sheath of the optic nerve decides to allow adequate decompression and incision of the optic nerve. This technique has been described and utilized by many authors and has been labeled by Sofferman as a standard surgical technique upon which virtually all reported theory of optic nerve decompression are based. And on this image, where it shows us the transfrontal optic nerve decompression via a right frontal craniectomy, the approach to the optic canal is shown, and the frontal lobe has been retracted and a portion of the bony optic canal unroofed, allowing expansion of the optic nerve and the dural sheath. A transethmoidal approach. In this approach, it assumes a prominent role for various reasons. The first is obviate the need for craniotomy. The second, this approach requires less time in fashioning and take less time to perform. At third position, this approach tends to be less invasive when performed when made endoscopically.
Arsene,
yeah.
Sorry. Where exactly are you? I think it's you're at the transethmoidal approach, right?
Yeah, we are at the transethmoidal approach. Yeah.
Yeah, but which one? Is it the transfacial transethmoidal approach or the transnasal?
Not this one. It is the transmedial approach in all the contexts, but we are not in the special type of this approach. So you can go back to the previous slide. Yeah.
Oh, this one.
On this one. Yeah. Okay. As we said, the transmedial approach assumes a prominent role for various reasons. And the first is this approach avoids craniotomy. The second one, this approach requires less time in fashioning and take less time to perform. And the third reason, this approach tends to be less invasive when it's made endoscopically, and it tends to be like a minimally invasive surgery. But this approach had two main drawbacks. The first one is a risk to injury to the carotid artery, and the second is a cerebral spinal fluid leak. This cerebral spinal fluid leak can be a result of two main reasons. The first reason is according to the removal of the bone over the optic nerve, and must be meticulous to avoid injury of the carotid with the carotid artery, as we said. And second, the optic nerve sheath may be be lacerated from the traumatic event or assist as a part of the procedure. But such opening in the optic nerve sheath can also lead to a cerebral spinal fluid leak. And as we said, the transethmoidal approach can be divided into transfacial, endoscopic, transnasal, and transconjunctival. And transnasal endoscopic is favored because of the proximity of the optic nerve to the sphenoid sinus, sand and noddy cell, and from some advantages like for external scars, preservation of olfaction, and decreased morbidity and faster recovery time. The next slide, please. The next slide, please, Ulrich. Okay. According to the transfacial ethmoidal approach, it is important to note that the fascial incision to medial aspect of the orbital apex is the beginning point of this surgical approach. And the vertical incision is made medial to the medial canthus. This we call the Lynch incision and allow to divide the medial palpebral ligament. Exposition of the ethmoidal sinus by resection of a novel bone near the maxillary ethmoidal frontal bones. And the next step is a removal of the mucous membranes and bone receptor of the sinus, which is followed by the prominence of the optic canal, which is found deep in the lateral recess of the sinus. And in case of fractures of the thin medial wall of the sinus, the bony fragment should be removed carefully. It is important to know that the optic canal is decompressed along the medial wall, but the compression of the optic canal is a subject of many discussion among many authors, and many authors are finding they allow to insist the optic nerve sheet, but others are not decided about which approach to do accordingly the incision of the optic sheet. But it's important to know that modified sphenoethmoid approach has been extensively described by Sofferman to improve the angle of approach. And on this image, it's allow us to show the left transethmoidal optic nerve decompression, and on the A image, the incision and the area of bone resection are outlined as we call on the according to the nose. On the image in the B position, the content of the ethmoidal sinus are removed, and it's followed by the optic canal. Then we say is found passing obliquely in the lateral recess of the ethmoidal sinus, and a portion of bony optic canal has been unroofed to allow inspection of the optic nerve and the optic sheet. The divided medial palpebral ligament is retracted with a suture, as it's shown on this image. Now about the endoscopic transnasal transethmoidal. Endoscopic, it began with an endoscopic ethmoidectomy, and then we enter in the sinus sphenoidal once it is identified. Then we proceed to the examination of the lateral wall of the sinus to find the prominences overlying the optic nerve and the carotid artery. It's followed by a bone removal over the thin lamina papyracea and proceed posteriorly. Drilling should occur under continuous irrigation, and this is important because it's allowed to prevent thermal injury to the optic nerve while performing the drilling. The optic nerve sheet may be inserted, as I said previously. This is a debate among authors because some authors agree with the incision of the optic nerve sheet. Some authors are not agree, but others authors are undecided accordingly the procedure to do while it is the issue of to insert the optic nerve sheet. But if there is any evidence of the cerebral spinal fluid leak, this issue should be treated with fibrin glue or dural substitute or cadaveric fascia lata. And it is important to note that transconjunctival exposure can be used to increase the orbital exposure when performing endoscopic approach, and approaches through orbits alone and nasal cavity together increase visualization for this approach. Now we are going to discuss about some studies accordingly to the transethmoidal approach, and some authors like Chen and all reported that the endoscopic optic nerve decompression can be safely and effectively achieved via a direct sphenoidotomy, which is performed through the sphenoid ostium in patients with high sphenoidal pneumatization and suprasphenoidal cells. The study involves 5 cases of traumatic optic neuropathy with a 45-degree angled endoscope used to read the optic nerve canal. Manually and all report a relative good risk-benefit ratio in patients with post-traumatic optic neuropathy when a protocol was followed, in which patients receive endovenous steroid therapy and no more than 8 hours after injury. With endoscopic endonasal decompression of the intracanalicular segment of the optic nerve performed within 12 up to 24 hours after the start of medical treatment. The study involved 26 patients with a maximum 24 1-month follow-up as a period. This image shows us a lateral wall of the sphenoid when we are decompressing the optic nerve via the transethmoidal approach through the transnasal canal. This image shows that we have a optic nerve and carotid artery which create impression on the lateral wall. The carotid artery is posterior and inferior in relation to the optic nerve. Therefore, we can see on this picture the optic nerve is exposure and should begin anterior and superior in relation of the optic nerve impression. Okay, then we can pass to the second image. This one shows us an endoscopic acid transorbital for optic nerve decompression. As we said that the conjunctival approaches when we are proceed by the endoscopic transethmoidal approach. This conjunctival approach allow us to have a good exposure of the structure, and this approach, as we said, the conjunctival has been fashioned to the periorbital, and the dissection of the periorbital should be careful from the orbital wall and ethmoidal artery, cauterized and incised. The lamina papyrosa has been removed, and drilling had begun to open the optic canal. As we said in the previous slide, it is important to, when we are drilling, to prevent the thermal injury which can occur while drilling. This lesion can be localized to the carotid artery. Now we are going to discuss to the last approach, which we call the lateral approach. This lateral approach can be divided into 2 subcategories. The first one is a lateral fascia, and the second is a lateral temporal approach that was described in the literature. According to all those approaches, there is a vertical or a mid-coronal incision which is performed, and limited anterior temporal craniotomy with a removal of the zygomatic process which is made. The next step is to this approach allow a direct exposure of the contact of the superior orbital fracture and the optic canal through the wide access to the lateral orbit is shown. And the superior aspect of the optic canal can be decompressed and the dural optic sheet can be inspected at the first time. The second time can be incised. As we said, the incision of the optic sheath can be discussed. This technique has a high risk for injury to the superior orbital fracture and the cavernous sinus through the extensive exposure of both structures. This is the first part of this presentation, and I didn't make a conclusion, but the important thing to know, according to the compression of the optic nerve, this should not be performed in all contexts of brain trauma, but the decompression optic nerve can be performed while we have already done all the evaluation of the optic nerve, the evaluation of the optic neuropathy, which in context of head injuries after some objective signs such as a visual loss, such as a diminished visual acuity or impairment of acuity. But the first thing to do in case of optic nerve injury is to make a treatment based on a corticosteroid therapy, such we can use such medicine like a methylprednisolone. That is the main thing to keep according to this presentation. And the procedure according to the optic nerve decompression, we have three categories: the lateral, two categories, the transfrontal approach, the transethmoidal approach. In the transethmoidal approach, we have many kinds of approaches, like an endoscopic approach, like a transethmoidal, a transnasal transethmoidal approaches, and in last time we have the lateral approaches. Where we are at the end of our presentation, we thanks we thanks everyone who take time to hear what we have to present about the decompression of the optic nerve, and we are ready to receive all comments, all questions, all add according to this subject. Thank you.
Thank you so much, Arsene. That was a great presentation, very detailed and very comprehensive altogether. I think there was more than enough information there. So before I give any comments, I'd like to welcome Dr. Meloni and Dr. Jimo. Hi, Dr. Meloni. So I'm sure they'll have a few comments to make there. I think you can start. If you have any comments, Dr. Meloni.
Well, first of all, my best appreciation for this panel because touch topics is very important in neurosurgery and very discussed ways the decompression of the optic nerve. I would just highlight how is in some techniques it's mandatory to have some endoscopic training because not all neurosurgeons are able to do endoscopic above all when you use this approach. We are most familiar with frontal or frontotemporal approach. Just that. but absolutely a topic of great interest. So
Okay.
thank you.
Well, thank you. Just a reminder, Dr. Meloni is a consultant neurosurgeon from Italy, practices in the north of Italy. We equally have Dr. Jimo, who's a practicing neurosurgeon from Nigeria, but currently in Morocco. Welcome, Dr. Jimo.
Thank you so much, Ulrich, and everybody in the panel. I'm happy to join this panel to listen to this very important but rare aspect of neurosurgery. I remember 10 years ago, I had a patient with optic nerve compression traumatic. And the situation then, it wasn't in the teaching hospital I saw the patient, the situation then could not warrant any surgical intervention. I tried to medically treat the patient by giving methylprednisolone, but the outcome wasn't particularly very good at the end. Now, I also, though I joined the discussion a bit late, there is an aspect which is very difficult, the diagnosis actually, because sometimes patients with traumatic nerve compression, the time you'll be making the diagnosis might be a bit late, because sometimes these patients come unconscious. By the time they are regaining consciousness, it doesn't give you the time to actually think of that very rare pathology for you to assess to see whether they actually have that problem. So it might be giving some difficulty in terms of making the diagnosis in the first instance. That's so a little experience I've got with this rare pathology. Actually, is the only one that I had come across about 10 years ago, as I said earlier on. So it's fantastic. And I joined midway. The presenter actually went to town in details to go step by step the principles of management, assessment, and also surgical approaches, even medical aspect of it. That's fantastic.
Thanks for your contribution, Dr. Jimo. Arsene, I will just make a few comments on the presentation. Once again, like I said, there are a lot of positive aspects. The presentation was really comprehensive, was really detailed. That's a really great work. It shows that you put in the work, definitely. So a few suggestions. I think these suggestions can help you get your presentation to the next level. So first suggestion is try and get little text on your slides. Don't get everything. Really short text, and you can explain. You're going to get the opportunity to present international conferences, so you want to get the attention of the audience. And if they can read what you're going to say, then it doesn't help that much. So try and get really short text. More explanations in terms of diagrams. You spoke about so much anatomy, operative anatomy. So we've been sharing some books in the group, and if you don't have them, just let us know so we can send it to you. So when you're explaining some of these things, you can have the images there, even for yourself. As a future neurosurgeon trainee, it's good to have those images because it's all about anatomy. You need to build up that thing. You need to build up that knowledge already. So that will help you. There was a time you mistook a CT scan for an MRI. So after this neurosurgical emergency lectures, after this, we're going to go on to neuroimaging. So I think we need to work on that and how you can systematically describe some of this imaging. So just be careful. Just be careful to know the difference. At least at your level, you should be able to know which one is a CT scan, which one is an MRI. The other details, I know you're still in med school, but the other details will come with time. But at least you should be able to make that a difference. And a few times, I think this must be just a mistake, but you want to be careful. Sometimes you spoke of optic nerve, sometimes ophthalmic nerve. So don't confuse the two. They're not the same, obviously, and I think you know that probably. It was really interesting that you spoke about reperfusion injury. So I would suggest that when you have time next, you should prepare a really nice presentation on reperfusion injuries and their links to neurosurgical pathologies. I think that will be very interesting for us and for yourself. It goes back to some basic science and should be really interesting. Altogether, honestly, really great work. You put in so much effort. We just hope to push you even higher and harder so that you can get something of even better and greater quality, so that when you get that chance tomorrow to present at international conferences, you're just at ease. You just feel like you've done this before. Thank you so much.
Thank you, Ulrich, for all comments, and I think next time I'll do better than I did for this presentation. And as it was prepared, we should present two topics. The one which is according to the optic nerve, the compression of the optic nerve, and the second to the compression of the facial nerve. If you can allow,
Yes.
we can put the next topic for the next Saturday for the presentation to the second part. I don't know if you have already added presentation, because I began the presentation, but I know I found the presentation I sent you.
Yes.
There is no the second part of this presentation, but in the second presentation I made some table, some imaging which can explain all the things according to these topics. And I think for the next time I will do better. I have to do better than it was now. And thank you for all.
Yeah, amazing. Thank you so much. Yes, definitely next week we can have two presentations, one of which will be the second part of the one you presented this time around. Yeah, and it will be a good way for you to just apply some of these comments and then just get it a step further. And really, I keep encouraging everyone that to participate. You should all try to do these things and present, because like I said, you're going to be submitting abstracts in conferences, you're going to be presenting these things, and what you want to do is when you go to conferences, there's like 200, 300 people presenting at the same time, and if you want to captivate people, then you need to have that little thing that makes you different from, otherwise everyone just blows past you. So you want to hone that skill. It's really good you're getting into this. Thank you very much.
Okay, thank you, Ulrich.
Is that Marvin? Did you have any comments? You're muted. If you can unmute yourself.
Yeah, I have two questions. Yeah, the first is, I don't know, from the presentation, I didn't get any consensus about the delay of surgical decompression. He presented two studies, one with 7 days, the other 3 to 4 days. So is there any consensus about the delay of surgical decompression? Then the second question, it's about the approach. He emphasized on the minimally invasive transethmoidal approach through endoscopy. I think I want to know if the supraorbital approach isn't better, because with the transphenoidal approach, there's a lot of risk of internal carotid artery injury, CSF leakage, whereas with the supraorbital approach, which wasn't mentioned during the presentation, those risks are minimized, and you have a good exposure, about 180 degrees of vision, which enable the surgeon to do a safe decompression, removing 50% of the roof of the orbital canal.
Yeah, thanks for your question. Daniel, if you have any answers, you can go ahead. Otherwise, we can always contribute. There's no worries.
Okay, thank Ulrich. According to the first question, for delaying the decompressive optic nerve compression, some studies shown that there is no any difference between performing the compression of optic nerve early and performing the decompression of the optic nerve after more days, like after 7 days. But the thing which we must keep in mind, according to the optic nerve injury, in context of head injury, in context of trauma, the main thing to do is the observation, because studies, some literature shows that there is no difference in performing observation alone and implementing a treatment accordingly, corticosteroid or the compression. According to the time for delay, the compression of the optic nerve can be instaurate in context of visual loss, as we said in the presentation, according to the damage of the visual acuity, and for patients which develop a visual which have a visual acuity damage persistent up to 1 year. But if I can go through the second question, we said the transethmoidal approach is better because this approach take less time to perform, is not need any surgical, any great surgical skill, but there are two main drawbacks for this surgical approach. As we said, the leak of cerebral spinal field and the lesion to the carotid artery. That shows that it is important to master the anatomy of the orbital complex and the optic canal. That is the important thing to know about these approaches. If there are on this question, I'm ready to receive.
Well, Tank, I'll just add a few things. So for the first question about whether there's a consensus or the management, the very first thing is, like Dr. Jimo said, this is a very rare event. So it's about 2.5% of skull base and anterior or middle skull base fractures that can be accompanied associated with these traumatic optic nerve injuries. So when you have, every time you have such a rare situation, it's difficult to have a consensus. So usually it's going to be based on practice. You have someone who's been doing this, who's a name in neurosurgery, and they will teach it to their residents. So obviously that's why you have all these divergence. If you have more cases, then it's easier to have more robust scientific studies, and then you can base it on it. So all the literature you'll find, it will be experiences, clinical, like to tell you it's a single institutional experience. We took care of this number of patients, and this is what we had. And what that means is it's actually about how you practice and how you learn. Because if you're in a center where they favor, for example, an endonasal approach, say, then obviously you guys at that center will be used to things like CSF leak. So you know how to avoid them and you know how to take care of them. If you're, for example, in a low and middle income country, then you don't have that many things to take care of CSF leaks. So you do everything you can to avoid anything that can get you a CSF leak, because you're thinking about meningitis and what can happen because you don't have the necessary equipment. So there you can have that discussion, I think. About the transorbital approach versus the supra, I think I'll defer to Dr. Meloni and Dr. Jimo if they have anything to say about that.
Well, I think yeah, I know. I like that I don't have a large experience in this topic because, as you just told, Ulrich is rare. But I think that when you perform a supraorbital approach, you're subject to risk of cerebrospinal fluid fistula because you have the frontal sinus. So if you perform a supraorbital approach, if you have a large sinus, frontal sinus, you need to cranialize. So you face this risk is intrinsic. Personally, I think that you need to, first of all, as I just told the colleague Abdullah, you need to perform a correct diagnosis. It's very hard sometimes because the patient is in coma. Can be sometimes helpful to have I don't know if you agree, a fundoscopic exam because you see venous congestion, papilledema. So you have already the suspect, and if it's associated with a CT scan, a bone CT scan that show there is a fracture and a possible compression in the optical foramen, you're authorized to check the patients and eventually perform a decompression if you see there are all this finding. You need also to keep in mind the problem of the internal carotid artery. Sometimes you cannot sacrifice the carotid internal artery, so you perform a transphenoidal and you cut the carotid artery. Of course, you put a patch, you can control the bleeding if it's a nightmare. But if you have a different flow from right to left, and you sacrifice the correct flow, I think that you worsen the condition of patients. So you need to be very to have a lot of attention when you decide the correct approach. Every approach, I think, has some tricks. So if you have, personally, if you have the opportunity to have more control, perform a frontal temporal approach is better. No time to have to have some minimal invasive or no scare approach. Just take care of patients and sometimes consider that the patients without with a visual defect survive. A patient with an internal carotid artery lesion sometimes cannot survive. So, be very careful. That's my
Okay, Dr. Jimo, if you have any comment on that.
Okay, Dr. Meloni has actually said comprehensively the blind spot of all this management of all this particular kind of rare injury. In my own suggestion, like he has partly said, in a setting where you don't have the luxury of all this minimal access or minimally invasive, and in addition, where your study, your preoperative image shows that probably there is another injury as well, it is better to go transcranial to try and sort out all these things at the same time, where you have access and good control of, you cannot joke around the internal carotid artery. So you be in a position to decompress the optic nerve transcranially and make sure that all the other vascular structures around are equally safe. Because there is no, it's not impossible that as well, the other extraocular muscle supply, the nerves, the extraocular muscle, the oculomotor, the trochlear, and all that could equally be in the harm's way. Going transcranial and microscopically, of course, which is easily accessible to. Even if you don't have the standard operating microscope, you could have a good magnification loop that you could use to really sort out this thing meticulously. Other than, of course, this presentation is very important. All get the scope of the treatment option surgically, but in this regard, as asked by Dr. Marvin, you have to be in a position to take control of everything practically. And in this our environment, you have to go transcranial to make sure all the anatomy is clear and you do what you want to do and get out. That's my suggestion.
Thank you so much. That was very enlightening. Dr. Marvin, are you satisfied with the answers?
Yeah.
Okay. Okay. Well, thank you so much. Thank you for attending. Thank you, Arsene, for a really brilliant presentation. We'll say to next week, we have another presentation. Thank you so much.
Yeah, okay.